Greeshma is she's a junior palliative physician here. She has around 2 years of experience in palliative care, and she is a well-versed person in this field. Ma'am, welcome and over to you.
Thank you, Sister Shiva. Good afternoon, all. Yeah. Today, our topic of presentation is pain management. I hope all of you have learned about assessment of pain in detail in previous session. So today we can see how it is to be managed. Okay, next. Today we will be seeing the basics of WHO analgesic ladder, step 1 and step 2 drugs and adjuvant drugs. Next. WHO analgesic ladder. Actually, this WHO has proposed this ladder, analgesic ladder, in 1986. Since then, it was not systematic for prescribing or starting any opioid or managing cancer pain. So, after proposing this WHO analgesic ladder, it became very effective and it is very simple and well validated. So, it is a step-wise approach to treat cancer pain. Okay, depending upon the severity of the cancer pain, now we have a systematic approach to manage pain. Prior to this, the patient were dying in unnecessary pain because of the stigma which is being associated with prescribing and taking opioids. Okay, next. And assessment of pain. This you might have seen in last session. So before managing a pain, we should know what type of pain it is. Okay, so there are many types of pain: nociceptic, neuropathic pain. So if you are not aware about that, you have to go through that in detail. Okay, in this session, we will be dealing with management of pain. And so before starting the management, we should be aware about the history of the patient, like what's the type of pain, what's the intensity, like that way. Okay, so there are two scales, visual analog scale and numerical rating scale. Next. Yeah. Here you can see the first one is visual analog scale. From there, from the emotion, you can even understand, even without asking the patient itself, you can rate, you can give a score to pain. And the second one is a numerical rating scale that you will be asking to the patient and you will be rating the pain. Okay, next. Yeah, types of pain also you might have seen in the last session. Nociceptic pain, it is again, it can be somatic as well as visceral. Somatic pain is mostly associated with bone pain, joints, connective tissue, muscle pain and all. And visceral pain is mostly associated with organs, heart, liver, pancreas, etc. And okay, after assessing the pain, we may have got some idea that patient is having mild pain, moderate pain, or severe pain, or a pain score of 3, or sometimes maybe 5, sometimes it may be very severe, that means even 10. So, according to the score or according to the intensity of pain, you now have this WHO analgesic ladder, and that is being shown in this picture, the second picture. Okay, so depending upon the ladder, we will be managing the pain. So if it is step 1, okay, if it is a mild pain, then what WHO analgesic ladder suggests is to start with non-opioid. Okay, but starting with a non-opioid or adding some adjuvants. You can add an adjuvant if it is needed or may not add an adjuvant. Okay, depending upon the severity, you can do that. And depending upon the type of pain, you can do that. We will be dealing with this in detail. Okay, that is the step 1. Step 1 is mainly for mild pain. Okay, the score will be less than 4, 3. Okay, 1, 2, 3. Okay, next. The step 2, or if the pain is not under control with step 1 drugs, then we may have to move on to the step 2. What is step 2? We will be adding a weak opioid for mild to moderate pain. Okay, so along with the non-opioid and an adjuvant, we will be adding a weak opioid. Okay, and we will be assessing the pain within a week or 24 hours or 48 hours. And after that, if the pain relief is not adequate, then we may need to optimize the dose of the analgesic. We may have to ensure drug complaints. If everything is okay, okay, you can continue the same. Or if the patient is not getting adequate pain relief, what is the next option? We may have to think about the step 3. Okay, so depending upon the pain score, the scoring is very, very important. You must know the intensity of pain, quality of pain, as well as the frequency of pain. Sometimes a patient might have pain only during the night. Then you may not need to give the analgesic throughout the day. So you can give the analgesic in the night. So you must first take the history properly about the pain, all the aspects you have to take in history, and after that, after getting a proper idea, you have to look into the WHO analgesic ladder. The step 1, which is for mild pain, that is a non-opioid plus or minus an adjuvant. We will be seeing what is adjuvant and all, what is non-opioid, what are the drugs. We will be seeing that. Okay. Step 2 is for mild to moderate pain, and step 3 is for severe pain. Okay, next. This is same only. Next. And now coming to the salient features of WHO analgesic ladder, it can be taken. It is advising that any medicine, any analgesic that can be started by mouth. Okay, oral route can be preferred. That is the standard route, and even for strong opioids, you can start by oral route. And only if the oral route is not feasible in persistent, for example, in persistent vomiting, or a patient may be unconscious, or there are many other situations. So, in only such cases, we will be advising what other parental routes. Otherwise, uh, the first thing is by the mouth. And what is the advantage of this oral route? It can be given in the home care itself, right? So there is no need to admit the patient to start or initiate any analgesic. So you can start the medicine in the home care itself. So we know the palliative care, we see most of the patient in the home care. So it is one of the major advantage. Next, by the ladder. That means you have to start, depending upon the severity, you have to give the medicine. So sometimes the patient may be in severe pain. So you need not to wait by starting the step 1. You can directly go to step 3 even. Okay, depending upon the severity. And by the clock means before that you have to analyze the pain and you have to take the history. And if the patient is having the frequent pain episodes during the daytime and nighttime, then if it is a continuous pain, then what we should do is we should give the analgesics throughout the day. Okay, the analgesics we give should cover uh, that analgesic effect throughout the day. So we should ask them to take the medicine at the correct time, and not when pain arises. Already we may be giving the pain medications, but some patients will take the medicine only when pain starts or only when they have pain. So that is not WHO analgesic ladder or WHO ladder advises. What WHO ladder advises is we should give an analgesic coverage throughout the day for a continuous pain. Why? Because if the pain starts and if the intensity increases and the threshold will decrease, and it will be very difficult for managing the pain. And if we are not giving the pain medication throughout the day, there is a possibility for breakthrough pain also. What is breakthrough pain? Before giving the next dose, the pain arises. So you have to review the patient, and on the follow-up and all, you have to take a note on that, whether the patient is having any breakthrough pain. For example, you are advising pain medication for 3 times a day, but patient is getting pain before the next dose. So what you should do, you should increase the dose or increase the frequency of medicine. So you should keep that in mind by the clock. So throughout the day, if the patient is having continuous pain, you should uh, optimize the analgesics. And the next, individualized to the patient. What does that mean? Uh, Sometimes the diagnosis may be similar in one patient and the other. Okay, but the pain score and the intensity they are suffering may be differ. So, according to uh, the pain score of each patient, the treatment will differ. So, you have to keep that in or keep that in mind. Okay, and the dose that is required to uh, get analgesic effect or pain relief for each patient also it will differ. So that also you have to keep in mind. And next, use adjuvant drugs. Okay, these are added at every step of analgesic ladder for specific types of pain and to decrease the undesirable side effects of analgesics. Okay, so along with a non-opioid or a weak opioid, you can add an analgesic. Why? Because the quality of pain or the nature of pain may not be one component. There will be multiple components that is being causing this pain. So um, we may have to support this analgesics with an adjuvant drugs. So we will be seeing that with examples in coming slides. And attention to detail. That means we have to be aware about the comorbidities the patients are having and the age and any other drugs they are taking, any other side effects. Everything we have to keep in mind. Okay, next. And step one drugs. That is being used for mild to moderate pain. And what are step one drugs? That is our NSAIDs. Okay, and that can be combined with in step one. That can be this NSAIDs can be combined with an adjuvant drug. Okay, next. Yeah, we know this NSAIDs even before we know palliative care, right? So this is being commonly used in our practices. So you might know the mechanism of action of NSAIDs before. NSAID is non-steroid anti-inflammatory drug. So which is the most commonly used NSAIDs in day-to-day practice? Yeah, ibuprofen is. Any other? Yeah, diclofenac. Yes, these are very commonly used, right? So, uh, here we will be seeing the mechanism of action of NSAIDs. Okay, so that inhibit the COX enzyme, cyclooxygenase enzyme. That is an important enzyme in the arachidonic acid cascade, which produce tissue and inflammatory prostaglandins. Okay, and these prostaglandins, which is being produced, mediate pain or that will sensitize, this prostaglandin sensitize the nerve endings and that lower threshold for pain. So, uh, what will happen when there is this prostaglandins which is being released? That will uh, that will cause the pain stimulus to reach the cerebral cortex easily. So, what this COX enzyme is being this NSAID is being doing, that will inhibit the COX enzyme. Okay. So this NSAIDs we prefer mostly in nociceptive pain. We know there are two type of pain, nociceptive as well as neuropathic pain. In nociceptive pain, there is evidence for very good relief with this NSAIDs for nociceptive pain. Neuropathic pain have NSAIDs in neuropathic pain has very less is very less effective. So you will be learning about neuropathic pain and its management in another class. Okay, next. So this is the pathway, or not pathway, this is the cascade. So when there is a tissue injury happens, what happens? There is a cell membrane. From there, uh, this phospholipase enzyme will convert that into arachidonic acid, and this from the arachidonic acid, this COX enzyme. There are two type of COX enzyme, isomerase enzymes, COX-1 and COX-2. Which will convert this arachidonic acid into prostaglandins. Not all prostaglandins is associated with pain. So here you can see arachidonic acid, the COX-1 will convert this arachidonic acid into PGI2 and thromboxane A2. And COX-2 here, it will be converting it into PGE2. Okay, so these are many types. Here you can see only three. There are many other prostaglandin type of prostaglandins, and that will be released, and all of them have a particular action. Here, first one, PGI2 have a gastric protective effect. Okay, and thromboxane A2 have a related to platelet function. That means that will help in platelet aggregation. And in COX-2, this PGE2 which is being formed is related to pain. So what will happen? This prostaglandin will sensitize the nerve endings in the tissue site, and that will amplify the pain, and that can even what that can cause, that can that pain stimulus can be taken to the cerebral cortex to the pain pathway. Okay, this you should keep in mind. There are two isomerase for this COX enzyme, that is COX-1 and COX-2. This COX-1 is uh, being stimulating, or that has an action on gastric protection and platelet function, and COX-2 is related with the prostaglandin that is being associated with pain and fever and so on. Okay, next. So this COX-1, whatever NSAIDs do, NSAIDs inhibit the COX enzyme, right? So this COX-1 is present in all normal tissues, especially GI tract, platelets, kidneys, etc. So that have a protective action, or which mediates a physiological response, and that has a protective action on our stomach, kidney, GIT in general, and platelet aggregation and all that will stimulate. So that have a protective action. And next, COX-2. COX-2 is involved in associated with inflammation, or whenever there is a tissue injury or an infection or inflammation, not infection, inflammation or injury, what will happen? This COX-2 is being stimulated, and that will uh, form PGE2, or that is being, that prostanoids is being related with what? Pain, and that is being present in lungs, brain, kidneys, testes, and which mediate prostacyclin synthesis, and that is being associated with vasodilator and inhibitor of platelet aggregation. Okay, next. So there are many types of NSAIDs. Okay, there are non-selective COX inhibitors, and selective COX inhibitors, and preferential COX inhibitors. Okay, first, non-selective COX inhibitors. That means that will be blocking the both COX-1 and COX-2. We have seen in the previous slides the COX. Can you please the previous slide? That diagram. Here. So if NSAIDs, okay, if non-selective NSAID, if it inhibit both COX-1 and COX-2, all these actions will be affected, right? So what will happen? The gastric protection will be affected, platelet function will be affected. But on the other side, when it inhibits the COX-2, the patient will have pain relief that will have an analgesic effect, and fever. When it acts on patient with fever, that will have an antipyretic effect, and it has an
वीडियो भी नहीं जा रही
anti
हाँ वीडियो भी स्टॉप करके
that also have an anti-inflammatory effect. Okay. Next. On the other side, inhibition of COX-1 will result in side effects. Next. Next. Yeah. What are non-selective COX inhibitors? Ibuprofen, naproxen, aspirin, piroxicam, mefenamic acid, ketorolac. All these are non-selective COX inhibitors. Okay, next. And mechanism of action of non-selective NSAIDs, we already see that inhibit both COX-1 as well as COX-2, but COX-1 inhibition will result in adverse effects. Why? Because the COX-1 is related with a housekeeping effect or a protective effect on our gastric GI tract. So that will result in bleeding, hypersensitivity, angioedema, urticaria, bronchospasm, etc. and renal effects also. And inhibition of COX-2 is preferable, and it has a beneficial effect, which is anti-inflammatory, analgesics, as well as antipyretic effect. Next. So side effects, which include renal. COX-1 is present in kidneys, and side effects will lead to sodium and water retention and acute and chronic renal failure. Okay, and gas in GIT, it may cause bleeding, ulceration, and hypersensitivity. It can cause in respiratory tract, skin, or generalized hypersensitivity can also occur. So you should keep in mind this. Okay, we will be telling that later also, but here you can see acute and chronic renal failure. So when you are advising analgesics in a or a non-selective NSAIDs or NSAIDs in general in a chronic renal failure patient, you should be cautious. Okay. Why? Because there is a chance for acute on renal failure. So, and when you are advising a patient, this NSAIDs in a patient having peptic ulcer or ulceration or a history of bleeding and all, you should be cautious. Why? Because this NSAIDs itself can cause what? Bleeding and ulceration. It can increase. Okay, and so all these things you should keep in mind. Next. And selective COX-2 inhibitors. What is this? That inhibit only COX-2. Okay. So the examples are celecoxib, rofecoxib, valdecoxib, parecoxib, etorecoxib, diclofenac, lumaricoxib. Next. The risk factors for GI toxicity, it is more. Here, this slide you can see what are the risk factors, and you should be cautious while if your patient is having all these things. For example, the GI toxicity will be more when the patient is having advanced age. That means age above 60 or 65, and high and prolonged use of NSAIDs when a patient is being advised NSAIDs for a prolonged time. So you should ask for what side effects or adverse effects in your follow-ups. Okay, and history of GI symptoms or bleed, and concurrent use of steroids, anticoagulant, aspirin. So, for example, sometimes for pain management, the patient may be taking the steroids in a low dose for a very long time without a PPI, proton pump inhibitor, or something else. And along with that, you are adding an analgesic like NSAIDs, then there is a more chance for this peptic ulcer as well as the bleeding. Okay, so you should, in follow-up, you should ask for any signs of side effects like gastric irritation, if it is any, or any increased risk of bleeding or increased bleeding spots or sites. Okay, so all these things you should keep in mind. Upper GI bleeding, how it will be presenting, how the patient will be presenting to you in follow-ups. Suppose a patient is having upper GI bleed, maybe a side effect of analgesics. So how your patient will be presenting to you?
Hematemesis, vomiting of blood, or passing of dark stools.
Yes, mostly passage of black stools, melena, or yes, there may be gastric irritation and may cause hematemesis as well. So all these things you have to keep in mind, or abdominal pain they may be complaining. Okay, so all these things you have to keep in mind. And next, risk factors for renal toxicity. Dehydration. Yes, we know whenever a patient is taking any medicine, they have to take adequate amount of water. Why? Because most of the medicines are being eliminated by our kidneys. So we should ensure the patient is taking adequate amount of water and use a concurrent use of nephrotoxic drugs, beta blockers, advanced age again, and poorly controlled diabetes. We know when a patient is having uncontrolled diabetes, there is a chance for nephropathy, diabetic nephropathy as well. So that you should keep in mind. And AC inhibitors or diuretics, creatinine clearance less than 30 ml per minute, these things, or renal failure patient, chronic renal failure patient, all these things are risk factors for renal toxicity. And next, risk factors for stroke or MI, again advanced age, diabetes, hypertension, hyperlipidemia, smoking, use of COX-2 drugs, all these things you have to keep in mind. Next. Okay. Here we will be seeing whether these COX-2 inhibitors are safe as compared to non-selective COX inhibitors. So comparing to GAT side effects, it is safe. Okay, but renal we have seen it is very comparable with non-selective NSAIDs only, and it has a prothrombotic effect, more likely of causing MI and stroke for COX-2 inhibitors. And the selective COX-2 inhibitors was actually taken off from the market in 2004 because of these adverse effects. Okay, so next. And precautions we should take with NSAIDs. When we are starting in NSAIDs for a long time, we may need to start this PPI also. And for example, if the patient is having some history, then we should definitely start. Need not to stall always, but when there is risk factors like all these things, we have to start. Okay, PPI, that is proton pump inhibitor, anything. Next, another thing is we should keep in mind the history of acid peptic disease history or advanced age, smokers, alcoholics, whether the patient is alcoholic, whether they are taking steroid, whether there is a history of CAD, hypertension, asthma, renal function, everything you have to be aware of. And if there is any tendency for bleeding or if they are taking anticoagulants and all, then we can avoid NSAIDs. And COX-2 selective inhibitors, it is being contraindicated in atherosclerosis disease, CAD, and cerebrovascular disease. Okay, so here it is being written, it is contraindicated, but in some cases we may need to give NSAIDs, but we should monitor and we should do the follow-up, we should review the patient, and yes, we should keep an eye on a patient, and if there is any warning sign, then we should stop it. Okay, and preferably, okay, COX-2 inhibitors have is being contraindicated, so that should be kept in mind. Next. And next, paracetamol. Okay, we know paracetamol, it is being widely used for pain, fever, For most of the, even if there is rhinitis or cold, even patient will be taking this paracetamol. So you might know the mechanism of action, and the name is acetaminophen, which has a predominant central action that inhibits the enzyme cyclooxygenase in the CNS. It has no peripheral action, so that will be having lesser side effects. So that has an antipyretic and anti-analgesic action, not analgesic action it has, but the paracetamol doesn't have an anti-inflammatory action. Okay, next. And what's a safe dose? We know in children and all, we used to start it at 15 milligram per kilogram dose. And in adults also, we can start it at 12 to 25 milligram per kilogram, 6th hourly. Okay. And daily dose is, it should be less than 4 milligram. Okay. Not 4 milligram. Okay. It's a 4 gram. Okay. And single dose should be less than 1 gram. Okay. 24-hour dose should be less than 4 gram. Okay, not 4 milligram, 4 gram. Single dose should be less than 1 gram or 1 gram also we used to give. And potential for there is potential for hypotoxicity. The chance of hepatotoxicity is there, but it is safe in liver disease patients, and up to 2 to 3 gram per day you can give. Okay. And rectal route, it is not preferred. Oral route is preferred. But when it is not feasible only, we advise the rectal route. Okay, next. Step 2 drugs. Okay, what are step 2 drugs? These are weak opioids. You can see it's codeine, tramadol, tapentadol. You might be using that in your setting also. Okay, next. So along with the NSAIDs, okay, along with the NSAIDs and adjuvants, if the pain is not controlled, then what we will do? We will move on to step 2 drugs. Okay, step 1 drugs we have seen in detail, that is NSAIDs and paracetamol. Along with that, adjuvant is there, that we'll be seeing in later slide. And here step 2 drug, that is tramadol. Tramadol, which have that is a opioid, but it is a weak opioid. Okay, so it has a central action. It's a centrally acting drug, and it's a 4-phenylpiperidine analog of codeine. Okay, it has dual mode of action. What are they? It's a mu opioid receptor agonist, as well as it blocks presynaptic reuptake of serotonin as well as norepinephrine. Okay, thus it inhibits the pain pathway. Okay, so this combination of this tramadol and paracetamol is being commonly used as a step 2 drug. Okay, next. So this tramadol has high oral bioavailability. So this oral route is even enough. We not to need what parenteral route or IV. Okay, the patient this tramadol when it is being given orally, that is a high oral bioavailability. So what's the oral dose potency? You might know morphine, which is a strong opioid. Comparing to that, it has a 1/5 potency of morphine when it is being given by orally, and 1/10 potency of morphine when it is given IV. So what's the equivalent dose? We have advised that this tramadol can be given at a dose of 50 to 100 milligram every 4 to 6 hours. But the maximum daily dose should be less than or equal to 400 milligram. So suppose a patient is taking this tramadol 100 milligram 6th hourly, and the patient, what will be the conversion dose to morphine? If it is orally, the potency is 1/5. So 400 times 5, what's that? 80. Or if it is IV, it will range between 40 to 80. That's all. Okay, so the potency you should know. Oral potency is 1/5 and IV it is 110. Okay, next. Tapentadol. Tapentadol is also a weak opioid and that also have dual mode of action, that is mu receptor agonist, as well as it also inhibits pain pathway by preventing reuptake of serotonin and norepinephrine. And the dose is 50 to 150 milligram 6th hourly up to 400 milligram per day. Next. So those are the step 2 drugs. Okay. From the step 1 itself, we were telling about adjuvant drugs. What are adjuvant drugs means? These are co-analgesics that is being added with step 1 and step 2. Okay. And here you can see it can be an anticonvulsant, can be an antidepressant, corticosteroid, bisphosphonates, cannabinoids, ketamine, neuroepileptics, anesthetics. Okay, next. So, what these analgesics do or why it is being added? That is a multi-purpose. For example, if the patient is having a new nociceptive pain, but along with that, some neuropathy component may be there. So, the major component may be nociceptic. So, what you can do is you can start with step 1 or step 2 according to the severity, and along with that, to cover the other uh, effects of pain or other cause of pain. Okay, you can add this adjuvant. For example, antidepressants is mainly add when there is a neuropathic component. So you will be learning about it later in neuropathic pain management. So you will have more idea. Okay, and corticosteroids. That also when there is some inflammation or when there is some edema, and this we know when there is a tissue injury, or for example we are dealing with the cancer patients and there may be peritumoral edema and all, so or when there is a meds, when there is a lymph node enlargement, what happens is the tissue around, there may be edema and there may be compression on the nerves, on the veins and all, on the near structures. So, if we can reduce the edema itself, that will help in pain management. But that alone cannot manage the pain. Along with the analgesics, if you are supporting by giving an anti-edema measure, okay, it can be pharmacological as well as non-pharmacological. Here we are dealing with analgesics, that means pharmacological management. So corticosteroids help in that. So what will happen? That will help in pain management. That will give more comfort to the patient. And sedatives. Okay, you can sometimes this lack of sleep that can cause the pain. That can increase the pain. Okay, sometimes pain itself can cause sleeplessness, but some cases in the patient may have sleeplessness at night, but during the daytime their normal pain score will increase when they have sleeplessness. So if we can support some sedatives in such patients, it will help them. Okay, when we are adding sedatives, we should keep in mind, okay, to start with PRN dose or SOS doses. And if it is very necessary, we can give it regular basis also. And antispasmodics. For example, if it is a nociceptic pain, but there is a colicky component or something, then what we can do? We can give an antispasmodic also. Here we have seen step 1 and step 2 drugs. All these drugs mechanism of action also we have seen, none of them have an antispasmodic effect, right? So when there is a colicky pain or a spasmodic pain, so what we should do, we should give some medicine, so you can support them with an adjuvants. And topical agents, sometimes the patient may have pain, severe pain, but for example in uh, peripheral occlusive vascular disease, okay, POVD, or peripheral occlusive arterial disease, POAD, or in some wound, diabetic wound. Okay, what we used to do here is we used to start step 1 or step 2 was according to the severity. But if the patient is having very severe pain, we used to give bupivacaine soaking. Okay, so what is that? That is an anesthetic agent, right? So that have a topical action on that wound site. Okay, so that will be giving some pain relief for the patient. Okay, these are the adjuvants. And specific type of pain, for example, bone pain. You know, in bone pain, we can give bisphosphonates, calcitonin, that will help in maintaining the bone strength and all. Okay, and musculoskeletal pain, we can give muscle relaxants. For example, when we are having some colicky pain or some, for example, in torticollis patients and all, you might have seen. Or when we have the spasm, muscle spasm, what doctor used to give? They will be giving muscle relaxant as well as an analgesics, right? So these are supportive analgesics or co-analgesics. And bowel obstruction, they are octreotide anticholinergics. These are the adjuvants. Bowel obstruction and all, that itself is an important topic, and you will be getting a class on that. So you need not to worry. Next. Yeah. I hope all of you are all of you got some idea on step 1, step 2 drugs and uh, adjuvants. And so we have enough time. So we will discuss, okay, how to manage pain and all. Okay, with some case scenario. I think today there is no case presentation. So anyway, we will be discussing with different scenarios. Okay. Uh, Before that, is this class, all of you are okay with this, or did you got any idea on step 1, step 2 drugs and adjuvants? Is it clear for all of you till now?
So thank you, ma'am, for the wonderful presentation. Anybody have any doubts?
Nobody has any doubt?
Yeah, if you have any experience also, you can share any patient story, anything if you want to share, please.
हेलो मैम, नमस्कार मैम। ये पीपीटी फर्दर स्टडी के लिए हम लोग देख सकते हैं या मिल सकती है कहीं पर?
Yeah, the PPT will be uploaded in an LMS study platform where you can take it from there. And all the learning materials, including the recording of the video, is uploaded in there.
Just after finishing of the class, sir, or just this completion of complete course?
It will take two to 3 days. You can obtain it from the IECO platform.
Okay, thanks a lot, sir.
Because you have to submit the assignments also. So before that, they will upload it. So that you can go through that PPT and attend that questions. Any more questions? So unfortunately, we don't have a patient story today for discussion. So that is one of the mandatory thing. Please bring your patient story, because we need a case patient story for discussion. So along with the faculty presentation, the faculty theoretical part, we need a patient story for discussion. So that you will understand more. So if we don't get a patient story from your side, it will be difficult to further. So we this is one of the mandatory thing. You should that submit your case presentation as soon as possible, because we need to get ready for that. And today also one of you has agreed to present a patient story, but morning you said like you didn't get time to prepare the patient story. That is not an acceptable thing. So I know you all are busy, so you will not get enough time to prepare the patient story. But if you think it, this is mandatory, then you will get time. You will find time from your busy schedule also. This is, please keep it in mind. It is a serious one, so you have to take it as a serious matter. So I think today's presentation is clear to everyone. Today,
Just discuss few scenarios.
do you have?
No, we can just ask.
Yeah, yes, please.
Yeah. Since there is no case presentation, I will be asking you some scenarios, so everyone should respond. Okay. These are very simple, and this is the first class on pain management. And if you are not interacting, then it will be difficult for you to understand. So, if you have any doubt, you can ask. For example, a 65-year-old patient with comorbidities like diabetes for 15 years, who is already on anti-diabetic medications but uncontrolled, is coming to you with a history or with a diagnosis of CA breast. Okay, so she is having severe pain. She is having an edema on her breast region and a wound also. So she is not on any analgesics, and her pain is continuous, and she's been telling that pain score is 5. Okay, so what you will be starting with, which medication you will start, which step you will be starting with, and what are the adjuvants you will be adding. She's having an edema, she has some redness, she has a wound. So here we are not intending to manage all the aspects, just pain management you can what you can answer. Okay. So
मैम paracetamol देंगे
yes, the pain score is 5, and it is a continuous pain, and she has sleeplessness because of pain, and she seems to be restless because of this pain and not comfortable. Okay. So which will be the better option? Sister Sapna has written in the chat that it's ibuprofen. Okay, any other answer?
tramadol
Okay, okay, tramadol. Any other? Is there any need for any adjuvant?
Tramadol, paracetamol. Tramadol.
Okay,
Opioid with adjuvant.
which adjuvant you will be preferring? Someone has answered corticosteroid, paracetamol, tramadol plus paracetamol. Okay, yeah. At what frequency you will be suggesting for a patient who is in continuous pain with a pain score of 5 and mostly nociceptic pain, but it is being associated with an edema and all?
Ma'am, TID.
Okay, any other answer?
6 hourly.
वाली दे सकते हैं मैम
Yeah. So Anyone wish to brief up the management from these answers? Okay, someone has told tramadol plus paracetamol. So why you chose that tramadol plus paracetamol? The answer is mostly correct. So that I am asking, if you can explain, it will be good.
मैम
Yes.
पैरासिटामोल भी है और ट्रामाडोल भी है, दोनों पेन क्लियर है, तो ये दोनों कॉम्बिनेशन एक साथ है तो दोनों से बेस्ट रहेगा रिलीफ के लिए।
Madam, your voice was not clear, so could you please repeat?
मैम ये पैरासिटामोल और ट्रामाडोल का दोनों कॉम्बिनेशन है और दोनों मिला के जो दोनों है कॉम्बिनेशन में, तो ये ट्रामाडोल जब देते हैं तो पेन रिलीफ अच्छे से होता है। मैम
Yes. Yeah. Someone has answered in the chat that tramadol plus paracetamol we prefer for mild to moderate pain. Yes. The score is yes, ma'am. We have combination medicines available in our pharmacy. Yeah, for the most common one is Ultraset. You might have seen this before, right? There are many other new combinations also, new uh, companies also available now. So if combination medicine they prefer, we can advise that. Why? Because the patient need not to take two medicines. Okay. If they are affordable or if it is available in your setting, you can give the combination medicine. There is no problem in that. So in this case scenario, this is just a simple example. The patient's age is above 60 and she's a non-case of diabetes, but she is being affected with what, or she's been diagnosed with CA breast and she is having severe, not severe, mild to moderate pain. The score is 5, that is moderate, right? So what we prefer is not step 1. We can directly go to step 2. What is step 2? Step 2 is a non-opioid plus or minus an adjuvant plus a weak opioid. That is tramadol plus paracetamol. Paracetamol is a step 1 drug. Tramadol is a step 2 drug. We can combine both these things. Okay. So step 2 is what we prefer. Why? Because the severity is score 5 and which is a moderate pain and which is a continuous pain. Okay. So if we give paracetamol alone, she may not get adequate relief. So we need not to wait for 1 or 2 days by giving this paracetamol. We can start the step 2 itself. But she's having an edema on that area and wound is also there. So some inflammatory signs are also there. So an adjuvant also we prefer. Which adjuvant? Someone has answered in the chat. Corticosteroids. Yes. Corticosteroids we can give. That is an anti-inflammatory as well as anti-edemal measure. So that will help in pain management and patient will be comfortable. And what you should do, the patient is a diabetic or even if there is no comorbidity also, you have to assess the pain after 48 hours or within 72 hours. Within 2 to 3 days, you have to assess the pain. If you are starting a opioid, whether it is weak or strong opioid or any other analgesics, you can follow up the case within 72 hours. And what you should do is the pain score is reducing or if the patient is having adequate relief, then you can continue that. If the pain relief is not adequate, then you can move on to the next. Or you can support with some other adjuvants also. And another thing is the frequency of medicine, the continuous pain. So what is the duration of action of all this tramadol, paracetamol and all? it will not be acting for more than 12 hours and all. So when it is a continuous pain, you can usually the THAF and all is 4 hours to 6 hours. So you can start with 6 hours. Okay. So tramadol and paracetamol you can start with 6 hours. 6th hourly you can start if it is a continuous pain. And corticosteroid, here we start with dexamethasone. According to the severity, we used to start sometimes at 8 milligram or sometimes 4 milligram and all. So these are the things. And in your day-to-day practice, what you should keep in mind is when a doctor is prescribing this medicine, you can just remain the doctor. The patient, okay, sometimes the doctor might have started this paracetamol, tramadol and all, or yeah, so you can just remain the, oh, the patient is having some edema also, so we have that space in your setting to discuss with the doctor, then definitely you should remain the doctor also if it is not done. And when we are starting a opioid, tramadol, or a morphine, you will be seeing, you will be learning about it in further classes. But here we are dealing with tramadol. So I would like to say, when we are starting an opioid, this tramadol has a action in GI tract, that will decrease the GI motility. The morphine also will decrease the GI motility. So what will happen is the patient may present with constipation in future days. So what you should do is you should make sure that you are adding an laxative also along with that opioid. Okay, whether it is weak or strong opioid, you should suggest and we should add a laxative also. Okay, it can be a stimulant laxative or a softener or combination. So that also you should keep in mind. You will be getting a class on laxative itself in future. So you need not to bother about that, but just keep that in mind. And this tramadol and all has a another thing is the patient may feel nausea for during the initial days of initiation of this tramadol and morphine. So you should also make sure that the patient is having some antiemetic. So about antiemetics also you should be getting class which antiemetics you should start when we start opioid and all. So these two things you should keep in mind. You should start an laxative as well as an antiemetic. Antiemetic, it can be given for few days. Okay, but laxative have to be given throughout. Okay, whenever or patient is continuing with opioid, then they have to take this laxative also. Otherwise, the patient may have constipation, and that itself can cause increase in pain if it is related to any abdominal pathology and all. Okay. And yeah, 6th hourly, you can start if the patient is having continuous pain, which is severe score or moderate score, which is 5. And okay. And another example, for example, if patient is having a diabetic foot, okay, what, having a pain score of 3, okay, diabetic foot, which is mostly neuropathic pain, okay, no, mostly neuropathic pain they will be having, but we didn't discuss about neuropathic pain. Anyway, if the patient is coming to you, okay, with a pain score of 3, non-case of diabetic foot, okay, what you will prefer from the adjuvant or anything? Did you get any idea which medicine to be started, or any analgesic, or which step you should prefer in that case? Okay. paracetamol. Any other adjuvant you can add? Anyway, when the pain score is 3, which is mild, so we prefer what? Step 1 drugs. Okay. And sometimes even if it is pain is continuous, if the score is less, we can start with step 1 and see. Okay, along with an adjuvant. Paracetamol you can give 6 hourly. Okay. Along with the adjuvant that we prefer is, why we prefer adjuvant in that case means that has a nociceptic as well as neuropathic component. Okay, diabetic foot, that means there is a wound. Of course, there is tissue inflammation, everything is there. So, what happens is there is an analgesia that has a nociceptic action as well as neuropathic component will be there in diabetic foot and all. So we prefer an adjuvant that has a neuropathic action, action on neuropathic pain. So that is our antidepressants. That also you will learn in your coming class. Here in our setting, what we used to start with is paracetamol. We can give for covering the nociceptic type of pain, and neuropathic, to cover the neuropathic pain, we will be adding amitriptyline. That is a tricyclic antidepressant. Okay, like tramadol, that also has a action on the pain pathway by inhibiting serotonin nor adrenaline. So you will be getting class on that, but just keep that in mind. Okay. So, and another thing is, for covering the nerve, for supporting the nerves and all, we used to give vitamin B complex also we can give. So if it is just starting phase, what happens is in diabetic neuropathy, that will help. Even with B complex or vitamin itself can relieve the pain. So these are the adjuvants. Okay. And okay, these are the two examples which came into my mind. And if you have any other doubt, so you can ask. So whichever case, you have to do the follow-up, and you need not to wait by starting step 1, step 2 and all. Some cases we can start even step 3 from the first day itself. So you have to know the scoring. The previous class you might have learned about how to assess the pain and how to score, it, and also everyone should be thorough about those things, and then only you can manage the pain. After starting the medicine, what you should do is you should do follow-up. Whenever you are seeing the patient in next visit, you should assess the pain. Sometimes the patient may be telling you that they are not getting adequate relief. Before going to the next step or before increasing the dose of medicine, you should ensure drug compliance also. Whether the patient is taking the medicine at prescribed dose. So that also you should ensure. Okay. Before ensuring drug compliance, don't hike the dose also. So you should make sure that the patient is taking the medicine, and if the patient is not getting relief, you can move on to the next, or you can increase the dose. Okay. And sometimes the patient may not be taking the medicine because there may not be proper caregiver, or there may not be they may not be aware to take the medicine and all. So depending upon each situation, you have to manage the pain. In palliative care, we doesn't manage the symptoms just by prescribing the medicines. Okay, we should cover all the aspects of pain. Okay, there are many other aspects also. So all these things you have to keep in mind. Thank you.
Thank you, ma'am. So any other questions? So I hope today's class is good for you, because you have learned many things from today's class, especially WHO analysis ladder step 1 and step 2. So we know what all drugs are comes under step 1 and step 2. So step 3 we will be discussing next class. So step 1, madam has discussed about paracetamol, NSAID. So NSAID, non-steroidal anti-inflammatory drug. So and also discussed about adjuvants. So we all understand that what is adjuvant. So what is adjuvant means it is a drug. The primary action is not an analgesic, but it can be helpful in some painful conditions. That is adjuvant. Okay, that primary action is not an analgesic. Okay, that is you have to keep it in mind all the time. The primary action is not an analgesic, but that particular drug is helpful in some painful conditions. For example, tricyclic antidepressants. For depression patients, you will give tricyclic antidepressants. These kind of drugs like amitriptyline or imipramine you will give. But that drug has a the analgesic effect also. That is why we said adjuvant. So if the patient is having nociceptive pain and neuropathic pain, you can add one of the adjuvant also. If the patient is having neuropathic pain, you can add any tricyclic antidepressants or anti-epileptic drug or anything, corticosteroids, anything. So that is called adjuvants. But otherwise, you can, if the patient is having nociceptive pain, then you can give that same pain analgesic medications like paracetamol, NSAID, or weak opioids or strong opioids. But if they have any nociceptive features, then you can add these kind of adjuvants also. And one important point I would like to highlight here is, we are not an authorized person to prescribe the medications, but we should know what all medications comes under in step 1, step 2, step 3, and also what is the maximum dosage and the side effect of medication. So the instructions that you have to given to the patient, so along with the NSAID, that is very, very important. Madam has mentioned clearly. So you have to tell them to take a plenty of water, adequate water, because the excretion is through kidney. So if you don't take adequate water, there is a chance of acute renal failure. One NSAID can cause acute renal failure. So you have to tell the caregivers and patient, this is very, very important. They have to take adequate water. And also the next thing is gastritis. So they have to take NSAID after food. That is the second instruction. And the third instruction, if they have a history of gastritis, you have to add any gastroprotective drug. That is pantoprazole or omeprazole, something like that you have to add. So these are the 3 instructions you have to give to the patient and caregivers. So after that, when they come for follow-up, you have to assess whether they have any side effects of this medication. So if you noticed something like this, you have to inform to the doctor. Okay, so that we can add something for them, and our aim is to improve the quality of life. No, so if they have developed these kind of problems, you have to add some the medication for that also, and also if they develop any bleeding or anything, we should stop that particular medication. Okay, so that is also very, very important. And adjuvant madam has discussed that paracetamol is also madam has discussed. So you can give as much as the patient, if the patient is having pain, you can add paracetamol any step. So you can add NSAID adjuvants or paracetamol in any step. Step 1, step 2, step 3. It's not contraindicated. Along with the other analgesics, you can add NSAID or paracetamol or adjuvants. So I think we can wind up. Anything you want to add, ma'am? So I think we can wind up the session. So thank you, Dr. Greeshma, for the wonderful interactive session. Thank you others for the interactions. Thank you.
Thank you, ma'am. Thank
Thank
you,
you.
Dr. Greeshma, for the wonderful presentation. Thank you, Shiva, ma'am, for facilitating. Thank you all for joining. Let's see you in the next session.
Thank you.